day.
Joining us now, Dr. Mark Horne, the Chief Medical Officer at South Central Regional Medical Center and past president of the Mississippi State Medical Association. Dr. Horne, thanks for joining us, sir.
Thank you. Can you hear me?
Yes, sir. We got you. So we wanted to have you on to talk about reports of drug shortages, in particular some drugs used in the treatment of cancer, chemotherapy drugs, et cetera. Tell us what's going on there.
Well, drug shortages is something we've been dealing with for quite some time in hospitals for several years, and it's a rotating, moving target. It's like whack-a-mole. We get things better here, it gets worse there. The current issues that are most significant and concerning are some chemotherapy drugs, particularly the platinum-based drugs like cisplatin and carboplatin. There's some others. Those are drugs that are really critical to the care of a large number of patients with advanced cancers, and they're very effective. They're not for everybody, but there are workarounds for some patients, but there's some situations where it's really the game in town.
What's the root cause of this problem?
I wish it was easy. Like so many things that we deal with, it's complex. I heard earlier you were talking about highly regulated utility industries. Well, medicine is a shockingly regulated industry. Sure. And that goes for the supply chains as well. So we run into things with a lot of the manufacturing has gone offshore. We have federal policies which have encouraged that in the past. So we moved it away from being manufactured onshore first to places like Puerto Rico. And then, of course, there was a hurricane, Maria, 2 or 3 years ago there, damaged a lot of those plants. And now it's gone to India and China. And so we're losing control in that route. Sometimes these other countries don't necessarily have our best interests at heart. That's one. Two, there are fewer manufacturers. So if something goes wrong at a plant, there are some drugs that are only manufactured at 1 or 2 plants in the world. And I don't know about the platinum-based products, but so you have very few manufacturers. If something goes wrong, the FDA shuts them down because of safety concerns, or there's a fire or some sort of accident or a hurricane, then there's a dramatic impact on the supply chain. So there's not enough redundancy in the system.
I think there's no doubt that, Dr. Horne, that during COVID, when we saw some issues with obtaining antibiotics, for example, that it brought it into focus that so many of the drugs that we consume here in this country that are administered, prescribed, aren't made in this country. And in some cases, they're made in countries that maybe don't have, as you said, our best interest at heart. It brought that to a head, and there's been a lot of discussion in Washington along those lines. Do you see any movement from the pharmaceutical industry to start to replant some of those facilities and manufacturing capabilities here?
I could think of 2 or 3 individual things. I know that the Ozempic line is entirely on U.S. shores now. That's a drug that most people have heard of. That's not something as critical. I mean, we're facing shortage of things like Solumedrol, Solucortef. These are basic steroids that are essential for a lot of treatments. And there are shortages. We have to worry about various anesthesia agents at times. And so I hope that our leaders will do everything they can to onshore as much of this production as we can. The same way that I've heard people talk about, we would not want to be dependent on food supply offshore. So we need food and medicine and shelter. Those are some kind of key things that we all need on a daily basis.
Yeah. No doubt about it. So how is our healthcare providers, oncologists, et cetera, especially with these chemotherapy drugs, how are they getting around this? Are there alternatives that they're able to obtain?
There's typically, like any good cook, if you're missing one ingredient, you sometimes know how to substitute another. So these chemotherapy regimens, you could think of them as recipes. You can fudge and change a bit. It may be as good, it may not be as good. And then what we're doing is there are various societies that have looked at this and they're saying, okay, you might like to use a platinum-based regimen here, but we know this other regimen is mostly as good. So why don't you use that for these cases and save the platinum-based regimens where they are truly superior.
Okay. So maybe in more serious cases, more acute cases where maybe
prioritization.
Okay, I got you. I mean, which is something you guys do in your line of work on a daily basis when you're dealing with a resource allocation. Well, gosh, it just seems like that maybe we'll get a clue and start addressing this. We certainly got a dose of it, no pun intended, during COVID, and then we had the baby formula shortage on the heels of that. Maybe we're starting to wake up in this country and realize that we can't be so reliant on other nations' production facilities to serve our needs. Sure would like to see some movement occur there. Is the medical community speaking up, Dr. Horne? Are you guys letting folks in charge know?
We speak continuously on a wide range of topics, including this one, and all I can say is hope springs eternal.
Yeah. Yeah, I hear you. Do you know of any situations where someone was scheduled for a chemotherapy treatment and it was then rescheduled, rescheduled as a result of lack of availability of these drugs?
I checked with our oncology department prior to this, and we have not experienced it locally. We've always been able to get just enough, just in time.
Okay.
But we haven't had certainty or confidence. We have to, wait and see. So we haven't had to do it, but I hear reports of that happening in other places, and it certainly would not surprise me given what we've experienced in challenges of getting adequate supplies.
Yeah, totally understand. We had Dr. Dan Edney, of course, the state health officer, on the program earlier today. We were just discussing the economic status of the healthcare industry in the state of Mississippi. You and I have had those conversations as well before. What's the latest from your vantage point?
Well, Dan and I talk about this with some frequency, and it's the same old story, and we keep giving the same diagnosis, and the patient keeps looking for a different explanation that will keep them from the obvious. And so we know what the root causes are. We don't have enough insured patients in the state of Mississippi. We have a very sick population. We don't do a good job of addressing social determinants of health. And, Dr. Ed Hill, our former AMA president from the Tupelo area and now in Oxford, has talked about that for years and for decades. Dan and our former state health officer, Dr. Dobbs, have all talked about this. It's the same story, and we get handshakes and we love what you do and we want to help you, and then it's like this latest $120 some odd million, I think it was, the legislature gave, but they said it's going to be a grant program this way, and then the way it came out, it had so many strings attached that a lot of the smaller hospitals that really need it aren't going to be able to use it. So
yeah, we talked about that.
It's very, very, very frustrating.
Well, and of course, while the $100+ million might be of some degree of temporary assistance, it doesn't really solve the underlying structural problem.
Root causes need to be addressed. The root causes are we need expansion of access to medical care. One of those things is to expand access to Medicaid to our working poor, not people getting a handout. It's literally people who work on a day-to-day basis at lower paying jobs who don't have insurance and need a hand up that'll keep them healthy and in the workforce. That's one thing. The other thing is reform that allows physicians, healthcare providers, hospitals to negotiate on a more even level playing field with our insurers, who are constantly crushing people who are providing the care. With prior authorization demands, they raise the cost of medicine to avoid paying. And we're still stuck taking care of patients, which we love to do. We love to do it.
Sure. Yeah, that's not going to change. And the situation is not a lot different across the rest of the country, Dr. Horne. I'm sure you've seen that as well. We got about a minute left. You've seen some of these prominent institutions that are in the red ink now.
Yeah, there are places we're actually doing okay. We have some red ink on our ledger right now. We're getting better, and we're not nearly as bad as some, and we haven't had any layoffs here in Laurel, thank God. But yeah, it's a constant challenge. It's getting worse. The workforce is another thing. We have to attract. If you're out there looking for a career, look at a career in healthcare, LPN, RN, medical assistant, physician. There's jobs everywhere. We could hire 30 nurses today.
I hear it from everybody in the industry. Dr. Horne, always a pleasure to talk to you, sir. Thanks so much for your time and your insight and for coming on today. Appreciate it.
My pleasure.
Dr. Mark Horne, Chief Medical Officer, South Central Regional Medical Center, has been our